Drugs for pain control. A lot of these, hopefully you'll know quite a bit about, because if there's probably any med you gave a lot in clinical, it would be drugs for pain control. So we're talking about analgesics, and so we have opioid and non-opioid. With opioids, we can have opiate agonists, we can have partial agonists, and we can have opiate antagonists. With non-opioids, we have NSAIDs, non-steroidal anti-inflammatory drugs, salicylates, which are, in a way, NSAIDs, and Tylenol. And I really should have written acetaminophen there. Opioids we tend to use for more severe pain, and then the non-opioids for lesser pain. The opioids have a tendency or the potential to cause physical and psychological dependence. So we want to make sure that they're being used appropriately. But when we're talking about pain control, we don't want to, make assumptions, I guess is what I'm trying to say, about the patient's pain. We want to make sure that we're doing what we can to control pain, and that may mean pharmacologics, and it may mean non-pharmacologics. So we need to know, all of those things. Examples of opioid agonists are morphine, meperidine, methadone. Meperidine you probably know as Demerol. They bind to opioid receptors to produce analgesia. They decrease GI motility, and so may be used to control diarrhea. At the same time, that's also a side effect. Can cause constipation, as we all know. We want to make sure that we have, assess neuro status, vital signs. Respiratory depression is obviously a risk with opioid antagonists or agonists. That's probably our biggest thing that we're concerned about. Some patients experience nausea and vomiting, and of course, tolerance can develop, especially if used over a long period of time, which has the potential then to lead to dependence and addiction. Addiction typically can occur after 3 to 6 weeks of continued use. So, that's why we want to use it for the shortest amount of time possible. Opioid partial agonists, what we mean here is that they don't bind with as many pain receptors as the opioid agonists do. They actually have an antagonist component, and so we want to be careful using partial agonists with patients who have an addiction to opioids, because it can cause symptoms of withdrawal. These medications have what we call a ceiling effect, meaning that they're only going to provide so much pain relief, and giving more does not provide more pain relief. So I think we're talking side effects, typically, again, dizziness, sedation, constipation, dry mouth. Serious side effects might include confusion, disorientation, respiratory depression, and the potential for abuse. Though you don't see these two drugs typically given for chronic pain that would lead to the potential for an opioid antagonist. These are going to block the opioid receptor sites, and so they're typically going to be used for opioid overdose. If we've got a patient with respiratory depression, we use it for general anesthesia. They're not coming out of general anesthesia. The biggest adverse effect is that it's going to cause symptoms of withdrawal, because it immediately blocks that, and they will come out of it. And if they were in pain before, they're going to be in pain, plus they are going to experience all those withdrawal symptoms just bammo. Naloxone or Narcan, it says IV only here, but it can be given IM. We give it IM to newborns. I don't want to say all the time, but we do give it to newborns IM. So it's IM or IV. Naltrexone typically is used for long-term abuse, whereas naloxone is typically used for an acute, such as general anesthesia or baby born to a mom who just received a sedative, something like that. Non-opioids, of course, are the drugs of choice for mild to moderate pain. We use NSAIDs for pain, especially if it's associated with inflammation. Examples are aspirin and your salicylates, ibuprofen, and ibuprofen-like drugs such as Aleve, naproxen or naproxen is the other name for that. Its mechanism of action is that it inhibits prostaglandins that cause pain and inflammation. So if you've looked at pain theories, you'll see that the release of prostaglandins is thought to play a part in the perception of pain. And we know that prostaglandins are an essential component in the cause of inflammation. And so that's part of their effectiveness is their anti-inflammatory property. The downside to this is that prostaglandins cause vasodilation, and so chronic long-term use of nonsteroidals can cause vasoconstriction. And the place we're most likely to see this as a problem is in the kidneys, and so we can see kidney damage as a function of, or as a consequence of, long-term or high-dose nonsteroidal anti-inflammatory drug use. Most commonly, when we think of adverse effects for NSAIDs, we think of GI irritation and bleeding. Certainly, your aspirins are going to have a bigger risk of GI irritation because of, they actually irritate the mucosa. Ibuprofen and naproxen have that potential, but they're not as bad as your aspirins or salicylates. All of these drugs have some antiplatelet component, and so can increase the risk of bleeding, especially in the presence of GI irritation. Aspirin, again, is the worst offender, but the others do have some of that. Another big risk, especially with aspirin and salicylates, is salicylism, and so this is simply a toxicity. It can damage the nerve endings in the ear and cause ringing in the ears or tinnitus. Eventually that could lead to deafness. and nephrotoxicity, as well as hepatotoxicity. Overdose can lead to respiratory depression and coma. And we're going to see respiratory depression because it's going to cause acidosis if we have an overdose. Acetaminophen, also known as Tylenol. And one of the reasons why I said, I should have listed it as acetaminophen on that previous slide is because we have to be really careful about patient teaching. I think more and more people are recognizing it, but, we give a patient acetaminophen for pain. If we call it Tylenol, then they might take an over-the-counter drug that has acetaminophen in it as well. Well, they're looking for Tylenol. They're not looking for acetaminophen. They don't make that connection. And so we need to make sure that we're using what the patient is going to see, terms that the patient is going to recognize that, hey, you can't say, don't take medications containing Tylenol, because the box doesn't say Tylenol, it says acetaminophen. So hopefully that makes sense. Acetaminophen also inhibits prostaglandin production, but not to the extent of the NSAIDs. And so it has a more direct blocking pain impulses. Typically, adverse effects with acetaminophen are very few. Some people experience GI irritation, and that can be solved by taking with food. The most dangerous potential adverse effect is hepatotoxicity, and that is somewhat dose-related, whether it's chronic overuse or a one-time large dose of acetaminophen. So your book talks a little bit about anesthetics. We're not going to get into anesthetics, so we're going to stop here with just these analgesics. So again, that's it for Unit 2. Woo! Thanks for listening.